Hello and welcome. My purpose in this video is to take an overview of pharmacology in psychiatry. I want to use the video as a stepping stone for discussing the overall issues with pharmacology in psychiatry in individual one-to-one face-to-face sessions. And leading on from that, look at specific indications and particular groups of drugs. But I thought it wise to look at the overall considerations first, particularly because I know pharmacology in psychiatry is baffling to the uninitiated. For instance, if you go to 9 wells, you've got a pretty good chance of being able to work out the diagnosis from the medications that the patient is prescribed. That doesn't work so well in Carsview. It has been calculated that the majority of patients prescribed the antipsychotic quetiapine are not suffering from a psychotic illness and have never suffered from a psychotic illness. I think the difficulties are aggravated by my impression that the BNF is less useful in psychiatry than it is in other fields of medicine. For instance, if you want to know what dose of chlorpromazine to prescribe, the BNF will tell you initially 25 milligrams 3 times a day or 75 milligrams once a day. Maintenance between 75 and 300 milligrams a day, increased if necessary up to 1 gram, 1,000 milligrams per day. So somewhere between 75 milligrams and 1,000 milligrams per day, with no help being offered in how to calibrate and organize getting from 75 milligrams to 1,000 milligrams. And it certainly makes no mention of David Taylor's point in the Maudsley that the minimum effective antipsychotic dose of chlorpromazine is 200 milligrams in first episodes and probably 300 milligrams in relapse. The difficulties are compounded, to my mind, by the issue that pharmacology is taught more robustly in some universities than it is in others. So, how to make sense of this field? Well, I would suggest to you that if you bear receptors in mind, things will start to make sense. Not just the receptors that you're targeting, but also the receptors that are affected and confer other actions, some of which may be helpful, and furthermore, the receptors that are being affected and confer disadvantage for the patient. So, for instance, haloperidol has a relatively high affinity for dopamine receptors. The maximum dose is 20 milligrams. Chlorpromazine has a lower degree of affinity for dopamine receptors. The maximum dose, as we've already mentioned, is 1,000 milligrams. Haloperidol is relatively specific for dopamine receptors and doesn't confer much in the way of activity at other receptors. Its main side effects are Parkinsonians conferred by the action of the dopamine receptors. Chlorpromazine is less likely to cause Parkinsonian side effects because of that lower degree of affinity for dopamine receptors. It does affect other receptors and confers a broader spectrum of side effects as a result. Staying with receptors, a receptor-based approach will help you make sense of some questions which will probably arise very quickly. For instance, why do we use second-generation antipsychotics to augment antidepressants in patients with unipolar depression who have never suffered from psychotic symptoms. You'll be looking for effectiveness and efficacy for the depression through the antidepressant, but if that's not conferring and bringing enough benefit, then using a second generation antipsychotic will bring effects at the dopamine receptors, and dopamine being a monoamine tracks you into the monoamine hypothesis of depression. And furthermore, the second generation antipsychotic has effect at serotonin receptors, so will give you a broader spectrum of effects at multiple relevant receptors and augment the effect of the antidepressant. So the combination of, for instance, sertraline and quetiapine does actually make sense. And furthermore, the quetiapine, unlike the sertraline, will bring a better night's sleep for the patient, which will potentially help them even more so, in addition to the effects I've already outlined. That brings me on to an overall point I want you to remember. That is the crucial role of the H1 receptor and the effects of any medication that has H1 receptor antagonism. Any medication which has H1 receptor antagonism properties will confer sedation, anxiolysis, and hypnotic effect. It will not cause a dependency, but through the H1 receptor antagonism effects, it will also bring problems with increased appetite, increased weight, and altered metabolism. In fact, as a general rule, you can generally say that any medication in psychiatry that brings anxiolysis, sedation, and helps with sleep and is not addictive will cause weight gain. Medications with the greatest degree of H1 receptor antagonism are chlorpromazine, clozapine, olanzapine, quetiapine, amitriptyline, mirtazapine, and these are also the medications that are most notorious for causing weight gain. Conveniently, they end with the four letters P-I-N-E. So the medications ending with pine are the ones most likely to cause weight gain. Looking at the spelling of the letters, any medication ending in PAM, diazepam, nitrazepam, will also cause sedation and anxiolysis, will not cause weight gain, but will cause a dependency. Aripiprazole is not on that list of medications causing weight gain. Aripiprazole does not have any effect at H1 receptor level. Aripiprazole is an exception. In many other ways, it is a partial dopamine agonist. It does not have any effect at H1 receptors, so it does not bring any risks of weight gain and dyslipidemia, metabolic side effects, but it does not bring any help with sleep and sedation. Final point I would add: reassure patients that psychiatric medications do not cause dependency problems and are unlikely to zombify them, for want of a better term, with the exception, of course, in the dependency stakes of benzodiazepines. Even if they don't vocalize the question, it is often a question that is on patients' minds. Finally, what books to use? Well, the BNF is useful up to a point and is a good place to start, but it does have its deficiencies in psychiatry. Neuroscience by Nomenclature, Zohar and Nutt, is a very handy little book which breaks down medications by their indication, their receptor activity, and their side effects. And finally, the Maudsley Guidelines to Taylor is an excellent book. It gives you good explanations, which helps to understand things and remember them, and also gives very, very convenient tables and comparisons. If you cannot find the answer in this, you probably should have been talking to a pharmacist to begin with. So, I hope this introduction to the overall field of prescribing and pharmacology in psychiatry is helpful, and we will use this to discuss the area further and then turn to specific indications and specific groups of medications. Thank you.